Hi everyone, today I'm here with Dr. Bhaskar, a cardiologist who's been in the field for almost 30 years. So before I go into the questions, thank you again, Dr. Bhaskar, for being part of this interview.
Welcome.
So could you give us a brief overview of what cardiology is? Because I feel like sometimes people aren't certain like where cardiology is in terms of like progression into it from a residency, or they like mix it up with like a cardiothoracic surgeon. Could you kind of give us an overview of what cardiology is and what cases it involves?
So cardiology is a subspecialty of internal medicine. You have to, at least what I did was do a medicine residency in internal medicine for 3 years, and then after that I applied for fellowship, and I got to a fellowship and I did my cardiology fellowship for 3 years. When I finished my fellowship, which was in 1993, it was a couple of years before actually stents came on board, and I did regular cardiology, but I did not do a specialized interventional fellowship. Some of my colleagues who came out the same year as I did subsequently did training in interventional cardiology on the job, although there was no formal interventional cardiology program at that time. So I do general cardiology, I do diagnostic cardiac catheterization, a lot of the non-invasive techniques in cardiology, and it's a long road. After your internal medicine residency, I did 3 years of fellowship. The last year I actually specialized in nuclear medicine. I did a research program in cardiac PET imaging before I finished my fellowship, and then after that I went into private practice. So this is, you do your medical school, you do your college, your medical school, you do your residency program, so that's 3 years, and then it's another 3 or possibly 4 years. Nowadays, cardiology is also branched out, super specialized into several different areas. One is called advanced heart failure, where you deal with very sick patients, evaluate them for assist devices, cardiac transplant, manage a lot of bad cardiomyopathy. That's a specialty within cardiology that requires more advanced training. The other two big areas of subspecialty in cardiology are electrophysiology and interventional cardiology. Electrophysiology has expanded tremendously. A lot of new devices besides the new medications, catheter ablation, defibrillators, closure devices for stroke. Interventional cardiology, obviously, angioplasty, stenting, atherectomy, and now especially with devices, there's also mitral devices, transcatheter aortic valve replacements, transcatheter mitral valve replacements, mitral valve clip. So a lot of procedural structural heart disease within interventional cardiology all changed during my career in practice of cardiology, because these were not there 10 years ago.
If someone doesn't subspecialize in those things, would they do more just diagnosing of cardiac issues like murmurs and things like that?
Right. So, for example, I'm in a subspecialty practice. I have 20 cardiologists in my group. At this hospital, there are at least 15 at Mercy General here. In my group of 15, there are 5 general cardiologists like me. There are 5 interventional cardiologists that do the angioplasty, stenting, structural heart disease, and there are 3 electrophysiologists. We are busy. I'm on call almost every few days, every third day. We, as general cardiologists, don't do as many procedures as the interventionalists or the electrophysiologists, but we do procedures. Procedures that I do are diagnostic cardiac catheterization, transesophageal echocardiography, things like electrical cardioversion, and so we're very busy. If you did not do those subspecialty fellowships, you wouldn't do those procedures.
Mm-hmm. Okay, and so could you walk us to a typical day in your life from when you come in to when you leave? So
today's Saturday, a little bit unusual day because I'm sort of called off call. I'm not on call at the main hospital here, Mercy General. I went to Mercy Folsom this morning. I actually started off Mercy General. I rounded. I had about 7 patients in the hospital here. Most of those patients were either post-operative or CHF, atrial fibrillation. So I rounded. It took me about 15-20 minutes to round on every patient here. Then I went to Mercy Folsom. I was on call there. So when I went over there, I had 3 consults for me to see. For example, today I saw 1 patient today with chest pain, elevated troponin, that had been cathed at a hospital in Southern California, but was treated medically, but she came back again with chest pain, so I had to make some diagnostic decisions. What do I do with her? Should I treat her with medical therapy? So that was one of the consults. The second consult was a patient that had slow heart rate, slow atrial fibrillation in the ICU with sepsis. And the issue was, would you put a transvenous temporary wire or manage it medically? Eventually the patient may need a permanent pacemaker. That patient was a sick patient in the ICU. A third patient I saw was a very interesting case where somebody came in with a stroke, possible TIA, and while the patient was being monitored, they essentially, on the rhythm strips on monitoring in the emergency room, thought they saw ventricular tachycardia. So they looked at the rhythm strips, they saw this arrhythmia, and the concern was that the patient had VT. It turned out, after I had a chance to talk to the patient and look at the actual rhythm strips, it turned out to be an artifact, not ventricular tachycardia. And it was interesting, but it took a while to sort everything out. So those are my consults I did. Then I also read all the echoes at the hospital at Folsom. And, and I'm done for the day today as a sort of an off-call at Folsom. In my regular day, I have procedures scheduled. For example, Monday I have 2 diagnostic CATs, a transophthalmic echocardiogram, plus about 10 patients in the office. So our office is located right next to the hospital, so you can technically go see patients in the office, go and do a procedure and come back, go to the hospital round and come back to the office.
And so when do you, what times would you come in and leave usually?
Right, so usually, for me, I usually get here around 7 a.m. And then I usually don't leave till about 6:30.
And so,
if I'm not on call.
So you have 5 days of that, and then 1 day of off call.
We're fairly busy. I work close to 85 to 90 hours a week. In the month of December, I'm going to be working every December day, including Christmas, except for 2 days. I'm on call somewhere or working. Okay. So this weekend, even though it's a very nice, easy day for me, I went in the morning, I run it here or there. I'm sort of off call, but I'm going to be home by 5 o'clock because I'm not on call at night. So, but I'm working today, so it's a day just like any other day. I can't go out of town. I mean, I have to go and do my work. For me, I'm on call every 4th weekend at Mercy Folsom, and I'm on call every 4th weekend here at Mercy General. So next weekend I'm on call here at Mercy General, and that's a bad call. You're 24/7. You're on call. So. But not everybody works at this, you can kind of choose your hours depending on how busy you want to be.
Did you just want to be more busy? Or?
Well, part of it was that we were very busy when I was younger, and we just haven't had enough doctors to loop the call schedule, but that's going to happen as time goes on.
How is the lifestyle of a cardiologist different from that of another specialty?
Yeah, so cardiology, if you want to really go into cardiology, like anything, any kind of job, your job becomes your life, basically. So most of my partners, they're devoted to their profession, and so they spend a lot of time in the hospital, and not much time at home, and they like it that way. I mean, that's how they ended up here. Okay, so it's a field in medicine where you spend a lot of hours in the hospital, and it becomes your life. You drive, and you're constantly reading on your field and taking care of patients, and it becomes your life, and sort of the family life, home life is not as strong. Now there are cardiology positions available, where you remember like office type cardiology and not so much time in the hospital. So they are available. Most cardiologists' lives are very busy in the hospital.
Do you do a non-clinical work as well, or it seems like you're so busy with clinical work? I don't know if you have time for that.
Yeah, no, non-clinical work, pretty much zero. Okay. I used to do some teaching when I was at Methodist. There was a family practice residency program that rotated cardiology. I used to do that. But I don't go to Methodist Hospital anymore, so the residents don't come here. So I did some teaching in the past. I don't do any research at all, unless I review some manuscripts for some partners of mine who publish more papers. But it's just for review of the articles they're submitting, because a lot of those patients in their research projects are actually my office patients. So I do that, but I don't do any clinical research or anything. That's part of my job.
And so if someone wanted to do like research or policy work, other things like that, how would you recommend they get involved in that as a cardiologist?
Right. So if you wanted to do that, they have to decide where they're going to go. Here, you can do research. There is a research institute, the Mercy Heart Institute here, which does it. And if you're interventional or EP, you get enrolled as part of one of the program directors, although you're not actually writing the publication yourself. There's usually one or two guys that do it, and you're part of multi-center trials, things like that. You get involved. There's a lot of research nurses there. But if you're talking about just pure research, you want to go to an academic institution.
So it'd be hard in private.
Yeah, private practice.
Are there any misconceptions about cardiology?
Well, no. I mean, it is a very glamorous field. There's a lot of stuff. You get a lot of patient satisfaction working, but you actually physically save lives, unlike some other professions where you just, temporizing this or that. But you can actually physically, 30-year-old patients come in with BTVF, sausative shock, and live to the 90 years old. You actually can make a big difference in cardiology. It's very professionally rewarding because you feel like you really helped people and you get the feedback instantaneously. I mean, for example, I couldn't ever gone into like oncology and things like that. Sometimes the prognosis is so poor, you don't feel like you're helping that much. But so one of the things, the positive things, it is a very glamorous field and you really get positive feedback. But some people do underestimate that it takes a lot of commitment. You really have to be driven to be successful.
So that covers the most rewarding aspects and maybe some of the misconceptions. What's the most challenging aspect of cardiology?
For me, just to keeping up with the literature, being right at, you just make sure you keep reading as the years go on so that you know what's going on, keep current. And then, it always keeps you on edge because things can happen, patients can go bad very quickly, and so you always, you get used to that and be always on the lookout kind of thing.
And since medicine in general and cardiology and all the other specialties even are advancing so quickly and research is coming out so quickly, how do you recommend staying on top of all that? Because there's no way I feel you can read every paper.
Right. So you can't, and so you count. You do is reading as much as you can. You keep up with your CMEs, you go to the conferences, you do all of that. And then one of the biggest things, especially when you work in a subspecialty group, is that your colleagues, the way that you see how they practice, because you're taking care of a lot of their patients. And so, for example, a lot of the electrophysiologists keep me very updated on management of arrhythmias, things like that, and interventional, so look at films. So it's very, your colleagues help keep you, as good as you can.
And so for employment types, you mentioned you worked in private practice earlier, or when you're starting out right away. Was that solo?
No, after I finished my fellowship, the way I did my trainings, I did my med school at Mount Sinai in New York. I did my residency at Baylor in Houston, and then I did my fellowship at Case Western in Cleveland. After I finished my fellowship in Cleveland, I joined private practice in Dayton, Ohio, and I was there for 10 years. And then after that, it was a single specialty practice, but then my wife's family, they lived in the Bay Area, so we moved and I joined Regional Cardiology, which is this group, which subsequently 2 years ago merged with Mercy Medical Group. And so I've always been in private practice since I graduated, and it's worked out.
And so it seems like there's still opportunities to do private practice in cardiology. How is working in private practice different than working like in an academic environment, besides things like research?
So one of the big differences in private practice, there's an economics driving it. So you're forced to work very hard because you have to, there's some economic pressures, and you have to do a lot of this stuff yourself. When you're in academic medicine, you have residence fellows. The actual call is call you have to take. It's like, so physically at night, 2 o'clock in the morning, 3 o'clock in the morning, you got to come in to the hospital. There's nobody, trying to manage stuff for you until you get in the morning. So you have to physically, be available to do all that work, which you would have to do in private practice versus, if you were part of academic medicine. I know in my attendings, the fellows usually took care of most of the work, so although they had to be aware of what's going on, they physically didn't have to, do the grunt work.
So it seems like that would be even more intense, and I'm assuming even for academic cardiologists, the work is pretty intense as it is.
Yeah.
So how do you recommend future cardiologists or even other specialty physicians prevent burnout?
Yeah, you got to take some time, time off, periodically to kind of rejuvenate, and you have to learn to pace yourself. It's a marathon, and you have to do it for many, many years. But there's a lot of physician wellness groups and things like that, and you have to learn what your body can do. You learn what you can and cannot do, and just always have the option to slow down if need be.
It seems like you don't really take too much time off to do that stuff.
Yeah, but I think that's all personality driven. You know, I mean, you know, there are cardiologists in my group that don't want to spend as much time in the hospital, and you know, the chosen options to try to spend more time at home, things like that. It's a lifestyle choice to some degree. It's harder to do it in cardiology than say some other specialties, you know, but it can still be done.
It seems like maybe you're very stress tolerant.
Yeah.
Do you think that's a natural personality trait, or is that something that
you probably acquired? Okay. Well, one of the things is the stresses tend to go down as you get more and more used to it, because you know how to manage patients and take care of them. There's always some unpredictability of what's going to go on, but it's usually these are very much algorithm driven, based on experience how to manage patients. Sometimes some bad outcomes tend to occur, but you get stressed with that. But you know, as time goes on, you get used to it.
Yeah, I feel like I'm one of those people that tends to be very stress intolerant, so yeah, I get like always nervous about everything.
Yeah, well, I mean, you know, one good thing about medicine, you can go into, there's so many different fields. Yeah, you don't even have to go into clinical medicine. You know, you can go to public health, whatever. So you got tremendous options after med school. You know, and so you know, look into it.
You mentioned some of your colleagues take a little bit more time for family.
Yeah.
How do you manage your work-life balance since you're working so much?
I mean, I try to do my best. You know, and you know, I have. You know, I had three kids, and you know, they're grown up now. One's actually just interviewed a couple of weeks ago. Yeah, she's finished, and she's now applying to med school. She's waiting a year. So, you know, but you spend as much time as you can, and you have to. You know, it's a priority. You know, you have to prioritize one versus the other. You know, and if you know, I think the new guidelines are that you want to try to spend more time with family. Is what they want the doctors to do. But and that's changing, you know. And I know, for example, some of the big corporations like Kaiser and stuff, they really want you only a set amount of time. They want you to work. They don't want to work you more than that. But it's just the way your job is set up, and you just take it from there.
Yeah, I remember talking to I think a hematologist, oncologist, or someone or another similar profession, where they're saying how it's one of those things for their field where you're gonna have to decide on if you want to do family or more work. Focus versus like some professions, like I was talking to a psychiatrist who said there's like ample opportunity to be really flexible and like have both kind of. But I feel like some specialties, I guess cardiology too, lends itself more to like really being all into cardiology or like.
Right. Yeah, it's hard to, you know, I mean, even between inpatient and outpatient, because we do both office. The mindset is very different when you're inpatient. You deal with all the sick patients in the ICU, on drips, pressors, you know, ventilators, and then you have this office patient coming because, you know, he's got some vague chest pain or something. And so on days when I'm only doing mostly office, and then when I switch back to the hospital, the mindset's completely different. Here you're spending a lot of time, and you know, you're doing a little bit of psychosocial stuff because the patient's talking to you. So you know, it's and whereas there it's just mostly technically driven. You know, and you know what you want to do, and you just look at numbers and look at the patient and quickly make decisions. Whereas in the office, you know, they want you to establish contact with them. You know.
How has medicine changed since you started practicing, and where do you see it going in the future?
Yeah, I think the major difference I've noticed in medicine over the last almost 25 years is that one was the advent of medical records, because everything used to be written in hand. So technology is now really influencing medicine a lot, so especially in the field of medical records, and everything is. I fortunately have Dragon now, so because I'm not a good typist, get data in.
Is that
quickly.
Dictation software?
Yeah, dictation software. So you don't, because I'm not a very good typist, and you never learned that many years ago. But so we got to get all the data into the chart electronically. So that has changed dramatically, and then the use of technology to manage patients has also changed. You know, monitors. Devices that can be done, mechanical interventions that can be done. You know, so even the CCU has changed. That the patients are much more easily monitored than they were like 25 years ago.
And so, do you think that there should be more data to manage over time? Or?
Right. Yeah. And also, I know, for example, it's kind of funny because is that even in medical school, it used to be we had these books like Brown-Wall heart disease and things like that to look up something, and if some weird syndrome came on, But now it's it's at your fingertips. You can just Google it, or up to do something. It's the software. You just instantaneous. You go in a patient's room, and worrying about what the differential diagnosis is and this weird syndrome that you hadn't known about. We'd have to go back and look at a textbook to try to find it, but here it's instantaneously. So knowledge can be acquired much faster now because the data is so quickly available.
I wonder when we'll be able to use AI to diagnose things, perhaps maybe better than we could by parsing through like literature.
Right, and so it's true that'll happen, but you're always going to need a human being because you read some EKGs and everything. And this classic example was the consult I did today, where I was asked to see a patient because they thought I had ventricular tachycardia, and clearly I looked at the rhythm strip, so you can see that. Now the computer would have definitely read it as VT, but when you actually looked at the strips and you actually mapped out, you found this just artifact was shaking on the paper, But there's no way a computer would be able to figure that out, Just by looking at it intuitively, you could know. And so, I don't think the human brain can be replaced. Okay. So.
How do you recommend new physicians manage their finances, or maybe set their career up to maximize their income and put themselves at a good place financially?
Yeah, the issue is going to be I don't think primary care, it's not, I'm just hearing, I don't know the actual numbers, but the reimbursement for primary care is very low for the amount of training that you do and all the time you take off. So, that's going to be an issue, how do they subsidize doctors, for doing all this training and time, and then when they get into practice, they own all the student debt and loans that they have to take. So that's going to be some kind of an agenda now, that somebody will have to kind of figure out. That could be a big problem. Because there is a difference between nurse practitioner primary care and MD primary care. The training involved is so different, and the cost consumption. So, that would have to be figured out how that's going to work.
So you think the best way for physicians to maximize their income would be to specialize?
Yeah, right now I think because the specialty incomes are much higher than primary care, and even with the extra amount of training that you have to do, I think it makes a difference. But I don't know what the future will hold because in the future, costs may be contained and everything will be capitated. So the management of a patient will be based on disease. That's all the amount of money that's going to be done. It may not make a difference exactly what you do, but I don't know how that's going to pan out for the future. Like any skill, if you have some specialized skill and there's not very many people that can do that skill, you make yourself a more valuable commodity. It's something that economically would be useful for you.
What tips would you give us to get into a good cardiology fellowship and a good internal medicine residency?
All right. Okay. So again, that's why I asked you before the interview. Does it make a difference when I graduated as to whether things change? Because I graduated in 1986. And I presume things still work the same way, but I know it's all different. Because I don't remember even interviewing for residencies for when I was mastering my residency. I think we just did your application, sent it out, and I ever remember reviewing it just like you rank order. I think I ranked 6 places for my residency. And then I ended up getting my second choice, and I don't remember interviewing anywhere. But now my daughter was applying and says, "Well, you have to interview for residency," so it must have changed somewhat. But I would presume that the criteria for getting into good residencies are, based on your board scores, your letters of recommendation, how you do on your clinical rotations. So you want to do as well as you can on those things. And then the same with fellowship. You want to get into a good residency program and then get good letters of recommendation. And there's no exams during medicine residency beyond just doing your board exams. But the letters of recommendation residency probably make the biggest difference in terms of getting into fellowship. With the caveat, there's one other thing that you can do, and I don't think it's changed yet after all these years, is that if you ever publish papers, it makes a difference. So I published when I was a medical student, and I think it made a difference for residency, maybe for fellowship, having first authorship publication. I did clinical research when I was a medical student, and so that made a difference.
Would you recommend those being specialty related? Like, were those all cardiology?
No, it was, well, this turned out to be a more, it was called biostatistics, epidemiology, that's what you've been researching, but it had to do with cardiology because it had to do with long-term survival post myocardial infarction, so it was a meta-analysis. So indirectly, but not direct cardiology, clinical type of stuff.
So at least maybe peripherally related?
Right, peripherally related, yeah.
Okay.
So.
You mentioned getting good recommendations and maybe good evals on your rotations and on in your residency. How do you recommend us get those good evals, either on rotations or in residency for fellowship?
Yeah, so good evals, I mean, when you do your clinical rotations, you want to impress whoever that you're rounding with or doing your rotations with. So, people, they've seen lots of different students go through the program, so they get an idea of who's good or who isn't. What I've generally found out is, the big tip is, if you go into a field, you're expected to know everything about the field rather than have it taught to you. It's what I've learned. So it took me a while to realize that. So, when you go to hematology or something, you're expected to know everything basically. But they'll ask you some questions, when you're making rounds, and you need to know it, before they actually, rather than learn it as part of the process. So the students that seem to know it before, rather than trying to learn it on the fly when they're actually doing the program, seem to get the better evaluations and tend to be at the higher end of the class. So, it took me a while to learn that was what, when you were a medical student or a resident, you needed to know the answers. You're not trying to learn the answers while you're making rounds type of thing. So, it's hard, but that's how that. So if you actually go into surgical rotations or whatever, you need to maybe ask the upperclassmen ahead of you what kind of questions were asked, things like that. Know all that stuff before you go. And I know it's sometimes a blur going through everything fast, just going from one to another. But before you go to the next rotation, make sure you understand generally what's expected of you, and try to do some advanced reading. So when you actually get there, when a question is asked, that you know the answer to that question.
It almost seems like a catch-22 where it's like, to get good evals, you need to know the material, but to know the material, you need to go through the rotation and then... Right.
So that's the paradigm. So, you're going to learn it as you go, but when they ask you questions, they really want to know whether you actually know it or not. That's how the thing happens. And then the exams, obviously, I don't know what it is. We had our, OB exam and whatever, and you had to study for that and take those. Then they also counted as part of, I think for us it was pass-fail the first 2 years, and then pass-fail honors the last 2 years.
How do you recommend, what tips do you give medical students or new doctors to become good doctors?
As a doctor, you always have, the biggest sort of emotion you need to have, or personality, is you got to be empathetic. You got to really know what the person you're trying to treat, how do they feel, what do they want from you, And if you can get empathetic and you can understand what they want from you, then it makes a big difference. Even if you know all the technical aspects, to understand how they're feeling, when they come to see you, or you're taking care of them at bedside. If you can put yourself in what they are feeling like, it makes a big difference. Because a lot of medicine is not just scientific; there's a human connection that you want to make through.
Yeah, one of the previous interviewees I interviewed a couple days ago mentioned that there's actually a lot of therapeutic value in just the human connection, even without the physiological changes that happen through treatment procedures and things like that.
Yes, I agree with that completely. I think it does make a difference.
Thank you, Dr. Bhaskar, for being with us. Thank you guys for watching. If you have any questions about cardiology, let me know, and maybe I can forward it to Dr. Bhaskar and we can get back to you. If you have any other questions as well, leave it down below. Let me know who you'd like me to interview next. And hope you guys have a great rest of your day. Take care. Thank you.
Thank you.
Thank you so much.